Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
This is Emily Brown, the Program Director at Cancer Support Community Atlanta. We do these education programs monthly, and we've started doing a quarterly genetics program talking about specific topics with the Northside Hospital Hereditary and Cancer Genetics Program. So we're very grateful for Jazmine. She is giving us her time today, and she's probably still got patients to see. I know she's very busy. So I'll go ahead and hand it over to you.
Okay, thanks, Emily. So, hi, my name is Jazmine. I'm one of the genetic counselors here at Northside Hospital. Just like to thank Emily and the cancer support community for allowing me to give another one of these talks. Gave one on breast cancer a couple months ago or late last year. So happy to be back and talking about colon cancer this time around. So I hope that you guys, learn a lot from the presentation. And if you have questions, we can definitely get into that towards the end. Okay. All right, so here's the topics of discussion we'll go through today. We'll start off with genetics and cancer, just with some analogies, so that we're all on the same page about basically how genetic mutations can lead to cancer. We'll go through some colon cancer fast facts. I'll highlight a couple of hereditary cancer syndromes that we think about when we see colon cancer and or colon polyps. But I really want to spend the bulk of the talk getting into like testing criteria, screening guidelines, and talking about family history. Now that I've been counseling a little bit longer and have had more chances to talk with patients, I know that there's a lot of questions centered around these things specifically. And we'll talk about testing logistics and insurance because people have a lot of questions about those as well. And as I said, time for questions at the end. So I'm starting off with one of my favorite visual aids, the one on the left. I really like this analogy. I think I use this analogy probably about 12 times a week because I see about 12 patients a week. So I'm always using this analogy, different ways, different forms, kind of changing it up so that it will, fit the person that I'm talking to. But basically, our genes is like our body's recipe book, telling us how to grow and how to develop. So you think about your favorite cake recipe. I like to use cake because for me, I feel like thinking about cake is a lot better or easier to think about than cancer most of the time. So if you have a cake recipe and it's missing the part that says to add flour, and you go ahead and you try to bake that cake, something is probably going to be wrong with it. The consistency, the taste, it will be off. And that's because flour is an important part of most cake recipes. And our genes work the same exact way. If something is missing in it, if something is duplicated, if something is switched around, all of those things can impact how that gene functions. And a lot of the genes in our body, some of the genes that we will talk about in this presentation, it's their job to protect our bodies from cancer or disease. So it's when they're not working that disease or cancer can happen. The picture on the right, just basically, it's just another kind of form of the same analogy. You have this normal gene, which is the instructions to make proteins, and proteins are what goes around in our body and does those jobs. So when it's working, you get a healthy, round, bright red protein. When you have a mutation, or maybe in this case, it's that recipe that's missing the part to add flour, then you get a protein that's damaged. It's misshaped, it's an off color. And again, this is just a visual presentation. So it will look a little bit different if you're talking about in the actual human body, but these are two really great examples that I kind of like to start off with that I think puts all of this into context. So with some colon cancer fast facts here, So the general population for colon cancer is about 5%. So general population risks means just the average person's risk to develop that cancer. For breast cancer in women specifically, it's about 12%. For colon cancer for men and women, it's about 5. So that translates to about 1 in 18 people at some point in their life will develop colon cancer. So the light gray section of the pie chart, 70 to 80% of colon cancers, or any cancer really, is due to sporadic mutations, chance mutations that are not inherited, but can arise for a variety of reasons. About 5 to 10% of all colon cancer cases, that's the hereditary part. That's the blue slice of the pie chart. And these are the mutations that can be explained because they were inherited from a person's parent. So it could be something like Lynch syndrome, it can be FAP, it could be MUTYH. Those are some of the syndromes that we'll talk about in the next upcoming slides. But the hereditary cases for cancer are much less than the sporadic cases. And then sometimes we can have familial cases of cancer. About 25 to 35% of colon cancers familial, which is a combination of genetics, lifestyle, environmental risk factors. See this a lot in families with colon cancer, also again with breast cancer, where you have parents and children who are affected, where you have a person and their siblings, and we do genetic testing on that individual, and maybe there's other people in the family that have had genetic testing and they're all negative. There's no hereditary mutation, but for some reason, all of these closely related people have developed this cancer. It could be a combination of any of these things. And then something else that I get asked a lot that patients wonder about, or what are the risk factors for colon cancer or cancer in general? A lot of these factors might be things that you recall your doctor talking to you about or to be aware of, such as your diet, weight, staying physically active. All of these things can impact your risk for cancer. If people have type 2 diabetes or irritable bowel disease, which is IBD, ulcerative colitis or Crohn's disease, all of these things can increase someone's risk for colon cancer. But I would say out of all of these things, the ones that probably carry the most weight are going to be the first three, which are age, colorectal adenomas, and an adenoma is basically a pre-cancerous colon polyp, and of course, family history of colon cancer or colon polyps. Those are the ones that are going to impact someone's lifetime risk the most. Okay, so the first syndrome or hereditary cancer syndrome that we'll talk about is Lynch syndrome, formerly known as hereditary non-polyposis colorectal cancer, or HNPCC. So if you see HNPCC or you see Lynch, those are the exact same thing. Sometimes the syndrome names may change over time, or they might change it to better describe the syndrome as time goes on. This is the most common hereditary colorectal cancer syndrome. I tell patients when you hear Lynch, think colon cancer. Those two go very hand in hand, and they're caused by mutations in the mismatch repair genes, or MMR for short. There's 5 of these genes: MLH1, MSH2, MSH6, PMS2, and EpCAM. And the cancer risks can depend on which gene has the mutation, or it can vary. So some of the genes like MLH1 and MSH2 have higher colon cancer risks than, say, PMS2. And basically what these genes do in our body is they're the body's spell check mechanism. So if you think about spell check on your computer or autocorrect on your phone when you're sending text messages. That's basically what these MMR genes do. They make a protein that goes around and finds those errors and fixes them. So you can imagine if your autocorrect went out in your computer or on your phone, or spell check on your computer, and you were sending someone a text message and it had a whole bunch of errors in it, it may not make a lot of sense when they're reading it. So likewise, if someone has a mutation in one of these genes and it causes that gene to stop functioning, errors and mutations can arise, and those can lead to cancer, because essentially a cancer or a tumor is cells with mutations or errors inside of it that won't stop dividing out of control. So the way that this syndrome is inherited is in an autosomal dominant pattern. This is another picture that I really like to show patients. If we get into inheritance, I think it's a pretty straightforward, clean, clear picture. But in this scenario, dad has the condition. So we'll say dad has Lynch syndrome in this case. So the check mark means that one of the copies of the gene is working, and the X means the other one is not. Mom, she's fine. She does not have any mutations. Both copies of her genes are working. So every time they go to have a child, it's a 50% chance that the child could inherit Lynch syndrome mutation, or a 50% chance that the child does not. So that's why testing is important for family members, or that's how it impacts family members when we identify somebody who's positive in the family. And it goes on, so on and so forth. So for the children in the kind of darker blue shirt, their children would also be at a 50% risk to inherit the mutation. The children in the light blue shirt, their children would not be at risk to inherit Lynch syndrome because they don't have it. And presentation can also vary among families. So Lynch syndrome doesn't always look the same in every single family. And that's usually the case for a lot of genetic conditions that, move outside of the realm of cancer. Humans are diverse. We're all different people, even when we're related to others. So not everyone in the family is going to present the exact same way. So this is some of the cancer risks that are associated with Lynch syndrome. I know this chart is a lot. I lifted it from the National Comprehensive Cancer Network, or NCCN for short. So this is basically where we go as genetic counselors, or even your doctors, your surgeons, your oncologists. They kind of lay out all of the guidelines for the various cancer risks. So it's a lot, but I'm going to highlight some things and walk you through it. So don't get too overwhelmed looking at all of the numbers and percentages. So the first thing I want to point out that these cancer risks relate to MLH1 only. So there's other charts that relate to the other genes that I talked about on that previous slide, but this one comes up first in the guidelines. So I'm just using this as an example. So as you can see in that first row, it talks about colorectal cancer. Average age of presentation is around the mid-40s. And then it gives the lifetime risk for cancer through age 80. So 46 to 61%. That's a pretty wide range. Usually when there's a range like that for any type of cancer risk, the assumption is that if the person has an extensive family history of colon cancer, they're probably going to hover more around that 61%. And if they have little to no family history of colon cancer, but still have a mutation, they might hover more around the 46% or 50% range. And we're comparing these numbers to the 4.2% in the general population. So you can see that it is elevated, hence why it's that increased risk. Something else to highlight is endometrial / uterine and ovarian cancer. I know before I said when you think Lynch, think colon cancer, but uterine cancer and ovarian cancer, endometrial cancer can also be seen in Lynch. And a lot of times this is going to what is what is going to present in the females in the family, obviously, because those are female organs. So a patient who is referred for, say, uterine cancer at age 46, I would be thinking about Lynch syndrome for that patient. Likewise, if I saw a patient who was referred for colon cancer at 46, I'm also going to think about Lynch. This box just pointing out that some of these cancer types are pretty rare in the general population to begin with. They're not cancer types that you would normally screen for, like gastric or small bowel. Pancreatic cancer, most people are not screening for unless they have a family history. Same with biliary tract cancer. So they're pretty rare to begin with. And while the risks might be elevated, as you can see in the column to the left, it's still not the same risks compared to like colon or endometrial cancer. And then the other thing to talk about is breast cancer. Usually is not the first, Lynch is not the first thing you're going to think. If you see a patient with breast cancer, you might think about the BRCA genes, BRCA1 and BRCA2. For those that might be familiar with those, and for those that are not, those are hereditary, like breast and ovarian cancer genes. But I will say I've counseled several families so far on Lynch syndrome, and there's always at least one person in the family with breast cancer. And if you test positive for Lynch, that doesn't mean that you're getting all of these cancers. That would be incredibly unfortunate, but no one really ever gets all of these cancers. A patient might have one, they might have two or three throughout their lifetime. And it's also possible that you could be positive for an MLH1 mutation and develop none of these cancers. So these are just some of the numbers that you can share with the patient. But again, this chart kind of lifted right out of the guidelines. So the same kind of numbers and things that your provider would be looking at when they're counseling you. Okay, so two other syndromes want to highlight. One is familial adenomatous polyposis, or FAP. The other one is MUTYH associated polyposis, or MAP. The polyposis is like colon polyps. So if the referral is for, family history of colon polyps or personal history of colon polyps, these are going to be the ones that I think about. FAP is caused by mutations in the APC gene. It's also an autosomal dominant inheritance. So thinking back to that picture that I showed with the dad and the mom and the X and the check marks, it's that same inheritance pattern for this condition as well. The unique thing about this one is that it's characterized by hundreds or thousands of colon polyps. So sometimes I will see, written on the referral or written in notes that I get for patients when I'm reviewing, personal history of colon polyps, like suspicion for FAP. And I'm, trying to see, well, how many colon polyps does the person have? And maybe they've had like 12 colon polyps in the past, like 2 or 3 years. Again, FAP, we're talking about hundreds to thousands of colon polyps. If you were to Google like the image of a colon of somebody with FAP, you would see what I'm talking about. They refer to it as a carpeting of polyps. It's just more polyps really than actual colon. Typically, age of onset for FAP is going to be between the ages of 10 and 16 years old. So it's usually teens that are kind of presenting with this for the first time, usually probably because they have a family member that has a lot of colon polyps or died of colon cancer, which would have triggered them to that teenager or person to be seen by a GI specialist. And if left untreated, and why I underlined untreated risk, is approximately 100%. So if you find out that you have FAP or you have hundreds and thousands of colon polyps and you don't do anything about it, your risk for colon cancer is pretty high, if not certain at some point. So the treatment usually is going to be a colectomy, so having the colon removed. If not a total colectomy, then maybe a partial colectomy of some kind. Just because the polyp burden at that point is so high, it makes more sense to have the colon removed than to just, there's no way to really remove that many polyps at that point. Other risks that might pop up in an individual or a family with FAP could be stomach, liver, and pancreatic cancer as well. For MAP, those are caused by mutations in the MUTYH gene. This condition is recessive, so you would need to have a mutation from your mom and from your dad in order to be affected with this condition. So again, kind of thinking back to that image with the mom and the dad, but imagine that the mom also had an X. So then each of their children would have a 25% chance to be affected with this condition. In terms of severity, it's less severe than FAP and usually has a later age of onset. So if I'm seeing a patient referred for colon polyps and they're 61 years old and they've had like 30 to 50 colon polyps throughout their lifetime, it's really MAP that I'm going to be thinking about more than FAP. I think FAP might be a little bit more known to physicians, so that one tends to get written down a lot more, when reality MAP might be a better explanation for what is causing that patient's colon polyps. This picture is just showing that there are other syndromes out there. So I said I was only going to highlight 3. There's lots of others. This is just a chart just to show those: juvenile polyposis syndrome, Putz-Jaeger, Cowden syndrome there towards the bottom, and then the inheritance patterns for those. A lot of them are very similar. Okay, so when should you consider having a genetic evaluation / genetic testing for hereditary colon cancer? A lot of this is going to be based on and centered around the guidelines. So these is when you might want to think about, seeking out some of this information. So if you yourself, so the first one usually applies to the patient, has colon and/or endometrial cancer, especially under the age of 50. So if you're 65 and you had colon cancer when you were 42, you should probably think about genetic testing if you haven't had it already. If you're currently 42 and have colon cancer, then yes, you would want to think about genetic testing, or your doctor may refer you for genetic testing. If you have a first-degree relative with colon / endometrial cancer under the age of 50, so these are parents, siblings, children, and they're under age of 50, you can think about it as well. If you have more than one first-degree, if you have more than one first-degree relative with colorectal cancer or endometrial cancer, that also meets guidelines. If you have 2 or more second-degree relatives, aunts, uncles, grandparents, same situation, that's a meeting guidelines. And if you have a personal history of 20 or more colon polyps, so this is throughout the lifetime. So you could potentially have 20 polyps on one colonoscopy, or you could have 20 polyps just over all of the colonoscopies you might have had in your lifetime. Or if you have a family history of colon polyps, that also meets criteria. And then I highlighted this one in yellow, not necessarily because it's particularly more important than the others, but if someone in the family has a known pathogenic mutation, you definitely want to consider getting testing done, because then we know there's a mutation in the family, and we can calculate what your risk for having that mutation is, and make sure that you're getting the screening that you need. Okay, so this slide, again, another one that I took from the guidelines so that you can kind of see what I'm seeing when I'm looking at this and talking with a patient. This is what I'm looking at. Does the patient fit any of these criteria? So the first one, kind of first one out of the gate, and that's why I highlighted it in yellow on the other slide, is a known Lynch syndrome variant in the family. If that's the case, you definitely want to think about testing. The second kind of big one is if the person themselves, so the patient I'm seeing, has that history under the age of 50, they can also have a combination of them and maybe a first or second degree relative also under the age of 50. And then family history. So usually this third section applies a lot to people who are unaffected. They do not have cancer, hopefully never will, but then their family history would need to fit within one of these parameters: a first degree relative with colon cancer under 50, more than one first degree relative, or several second degree relatives with colon cancer or other Lynch syndrome related cancers. So that can start to include the things like ovarian, gastric, prostate, pancreatic, again, because every family is going to present differently. So it's not always going to be colon cancer every time in every family. Okay, so my genetic testing came back positive. What do I do now? So you've talked with your counselor, they've gone over the criteria, you meet criteria, you decide you want to do testing. These two pictures are from actual test reports of people who have tested positive. Obviously, their personal information has been eliminated for HIPAA reasons. But these are two different reports from two different labs. And I included them because one patient has a mutation in MLH1 and the other patient has a mutation in PMS2, and they both have Lynch syndrome. So the things that I boxed in red for the picture on the left, that says MLH1 pathogenic mutation. That's basically the lab's way of saying positive, which you can see is written in all caps, very clear. And then that little alphanumeric code there in that first red box is basically the address of the mutation. So if if someone wants to find where you live, they would need your address. If we want to find where the mutation is, in this case, that's the code that we need. And then in the one on the right, similar thing, you can see that this patient has a PMS2 mutation. It has its own little alphanumeric code. It's pathogenic. There should be no question whether your results are positive or not. That's two reasons why I really like using these particular labs. The reports are very clear. It's written, as I refer to it, as the big blue box. If it's coming from the lab that's on the right, I tell patients, like, if it's in the big blue box, then it's something to note. It's something important. The patient on the right had 84 genes tested in that panel. And the only two things that came back was that PMS2 variant and then a very uncertain variant in POL, which just means that they don't have enough evidence to say if it's positive or negative. That means the rest of the 82 genes were negative, so they don't put it in that little box. So what do you do next once you have these results? Screening, which is what we'll touch on in the next slides. You'd want to share your results with your provider/genetics professional. So if you saw a genetic counselor, likely they already know this result. They would have received it, reviewed it, and they're probably going to be the one that calls you and goes over it. But if you did this patient-initiated testing, or maybe you went to your primary care and they're not as familiar with these tests or how to interpret the results, then you would definitely want to seek out a genetic counselor, a geneticist, a genetics nurse who can either review the results with you or point you in the right direction. And then, of course, you want to share these results with your family because this is going to impact other people in the family besides yourself. So here are the screening guidelines for Lynch syndrome. Again, these are mainly dealing with MLH1. Each gene will kind of have its similar management, but they might start at different ages. So for the colon cancer, if you're MLH1 positive, you're going to have a colonoscopy starting between the ages of 20 to 25 every 2 to 5 years. 2 to 5 years before the earliest diagnosis, and then repeating every 1 to 2 years. If it's PMS2, I believe the age to start is between 30 and 35. And that's because the colon cancer risks for PMS2 are lower than the ones for MLH1. For the endometrial and ovarian cancer, usually it's a woman would have her ovaries and or uterus removed on the completion of childbearing. So people will learn this information at different stages. Some of my patients might be 69 when they find out that they're positive for Lynch syndrome. Some patients might be 39. Those are different ages. The 69-year-old female patient, it may not be too much of a concern for her to have her ovaries and uterus removed. She's not having children anymore at that point. The 39-year-old might be still considering expanding her family. So then they would remove those organs after she was done having kids, if children is something that she wants. And then for the gastric, small bowel, like bladder, pancreatic cancer, all of those screenings are going to usually depend on if you have family history. So if you do not have family history of gastric cancer or family history of pancreatic cancer or small bowel, you're probably not going to be doing these screenings. You might still talk to your doctor about them and have them kind of decide and walk you through whether that's something you need to be doing at this point. Family history can change, so that, someone could later down the line develop one of these cancers, and that might trigger you to start screening for them. But usually, if that's not the case, then you wouldn't need to. And as far as like the breast cancer goes, those screening guidelines are usually about the same for just like general population, making sure you're getting your mammograms every year. Unless there's like family history, then that might change for you. Okay, so why is screening important? So a lot of times people ask, what's the purpose of doing all of this, especially when patients, already have been diagnosed with cancer. And then for those that are unaffected, well, what's the point? You can't really stop the cancer from happening. And that's true to an extent. We don't have a cure for cancer, at least not yet. But the whole purpose of doing this type of screening is to determine, are you in a high risk category? Do we need to watch you more? Or are you in a general population risk category? So getting a colonoscopy reduces the incidence of colon cancer by detecting and removing pre-cancerous polyps. Colon cancer can be a slow growing cancer. Sometimes people find out they have colon cancer and it's from a polyp or polyps that have been there for several years. They just didn't have any issues. You obviously can't see the inside of your colon, so you wouldn't know it's there. And then eventually those issues start to arise. And by that time, it has developed now into cancer. So if they keep getting removed because you're having colonoscopies frequently, then they don't have a chance to become cancerous. And of course, it reduces mortality because you're detecting cancer at an early and a curable stage, or when you can do more about it and have more options, and more options for chemo, more options for radiation and all of that. So that's why it's important. If you're not going to make those changes or do the colonoscopies or any of the other screening guidelines, doing the testing itself is just kind of getting information for information's sake. The power is in what you do with it after. So this section is talking about family history. So another thing that I've seen come across referrals a lot, whether it's for colon or for breast, is, oh, I'm doing this genetic testing because I need to know when I need to start having a mammogram, or I need to know when I need to start having a colonoscopy. And I'm looking at the patient's chart, and the patient is 50 years old. And I'm like, well, if you're a female and you're 50, you can start your mammograms at 40. So you don't need to necessarily have genetic testing for that. And if you're 50 years old, national guidelines now recommends colonoscopies start at age 45 or older. So again, you don't really need genetic testing to tell you whether you should start some of these things, especially if you are at a certain age range or stage in life. So the first two sections of these charts talk about Lynch syndrome and FAP, which we kind of discussed on those other slides. But the last two sections relate more with family history. So if you have a first-degree relative with colon cancer, you should be starting your colonoscopies at age 40, or you might start 10 years before the youngest diagnosis. So for example, if your dad had colon cancer at 55, you would start at 45. If he was 45, you start at 35. If he's 35, you start at 25, and so on and so forth. If your relative was 60 or older, then you might start at 40 to 45 years old. And this is all based on family history. No genetic testing has been done in this case. This is all just based on family history. So sometimes you might qualify for having an earlier colonoscopy, not because you did genetic testing, not because you're at risk or for having a hereditary mutation, simply because your family history suggests that that would be beneficial for you. Again, another screen grab straight from the guidelines, just to further reiterate this point. So this talks about increased risk based on positive family history. So this could apply for people who do not meet criteria for testing, or for people who they might meet criteria, but they just haven't had testing done for some reason. So again, first-degree relative, parent, child, or sibling with colon cancer, you're going to be starting your colonoscopies at 40 or 10 years before. If it's a second or third degree relative, so second and third are going to be aunts, uncles, grandparents, cousins, you start colonoscopies around age 45. If none of this applies to you, no one in the family has any, colon cancer of any kind, then you can start at age 45 or older. So the guidelines can apply to hereditary cancer syndromes, but sometimes people just have family history of colon cancer. It's not due to a hereditary reason. As we discussed several slides back, 70 to 80% of the time, it is sporadic cases of cancer, but it still might be beneficial to start having a colonoscopy at an earlier age. Again, early detection, that is the goal. Part of the reason why I picked this topic is because I participate in the colorectal tumor boards that happens every other Tuesday here virtually. So it's where all of the oncologists and surgeons and pathologists and radiologists discuss cases. And I can't tell you how many cases there where people have, colon cancer, no family history of colon cancer whatsoever, but they, either the first time they got a colonoscopy might have been like their late 50s, their 60s is the first time that they presented to have that screening done. And, they could have started much earlier, or they didn't necessarily have to wait, or if they were advised to wait, that's not the case anymore. Okay, so this is a pedigree, basically just a family tree. This is usually what a genetic counselor is going to draw when they're reviewing their family history. So this is a pretty kind of textbook Lynch syndrome looking family, if I was taking this family history and a patient mentioned this information to me, I'm going to be thinking about Lynch syndrome. But even if we were to pretend that we didn't know that this had anything to do with Lynch syndrome, and say that this was my patient here in the orange box, this patient, her children, if she had children, they would start their colon cancer screening at age 27. So that's how the family history plays a role. There's no testing has been done at any point, but her children are still going to start at 27 because their mom was diagnosed at 37. Likewise, for her uncle's children, he was diagnosed at 42. His kids, so these would be her cousins, his kids are going to start at 32, and that's because he was diagnosed at 42. But in this case, we do genetic testing, and we find out that the patient is MSH2 positive. So this is another Lynch syndrome gene, a different one than the ones that I showed from the test reports. So this pretty much explains, why this patient has gotten colon cancer at the age that she did. And then some other people in the family do testing. At this point, her brother and her parents each have a 50% chance to also be positive. The patient's children have a 50% chance to be positive for this mutation as well. Her uncles and her aunt have a 25% chance, and then her cousins have a 12.5% chance to be positive. So it halves every degree of relation you move out or away from the patient, it goes down by half. So some other people do testing, and we find out that this uncle is positive. He doesn't have cancer, but let's just pretend he's the baby of the family. He was the surprise child, so he's like 10 years younger than the rest of his siblings. So maybe he's not in an age range where we would expect to see Lynch syndrome presenting. So he's unaffected, but he's positive. And then his daughter does testing, and she's negative. She did not inherit that mutation that her dad has. So she is a true negative. We know she does not have that mutation. She's basically removed from the Lynch syndrome risks. I would still say that it would behoove her to have earlier colonoscopies, but as far as her having those same risks that her cousin and her dad and maybe probably the other people in the family that might be affected, she's not at that same level. And then, the aunt that passed away, maybe she didn't get testing before she passed. And these cousins over here, the uncle with colon cancer at 42, his children would be recommended to have testing, as well as the aunt, if the aunt had children. Something else that sometimes comes up is I'll be talking to a patient and I'll say, well, family members might be at risk for this. And she's like, oh, well, my brother's not interested. He's not going to do this. The whole ignorance is bliss approach, which is fine. Patients, if they're adults, they have the choice. They can make that choice. But he would still need to be screened as a Lynch syndrome patient, because we know that his sister has Lynch syndrome. We know it's in the family. And because we are not 100% certain of his genetic status, he would still need to be screened with those guidelines. So her cousin, she knows her status. She knows she doesn't have to screen as a Lynch syndrome, as a person with a risk for Lynch syndrome. The patient's brother, we cannot say that about him because we don't have that information. Sometimes there's people in the family who just don't want to get testing. They don't want to know. But I will point out that because the patient is positive and we know that her uncle is positive, this kind of inadvertently discloses her mother's status, that her mother probably has this MSH2 mutation. So if her mom didn't want to know, she kind of knows now whether she did the testing or not. So that is something important to be aware of, that sometimes people's status are going to be revealed if everyone around them starts testing positive, it kind of boxes them in there that they likely also have the mutation. These are just other pedigrees. I don't know how we're doing on time, but I basically just threw these in there just to point out that these are types of family histories I see a lot. 35-year-old patient comes in, the referral is family history of breast cancer, and that's where the concern is. But I think, since we've been talking for a little bit now, you guys might be able to appreciate that dad's side of the family also looks suspicious. Dad has colon polyps. His sisters had endometrial cancer. Their dad has had colon cancer. Dad's side of the family looks suspicious for a hereditary colon cancer syndrome. And actually, this patient meets guidelines for colon cancer genes and not breast cancer genes, because her mom and her maternal grandmother, their ages at which they had their cancer is not suggestive for her breast cancer syndrome. So I see this a lot and point this out to patients as we're talking, that doesn't change the fact that her mom or grandmother had breast cancer, doesn't change that at all, or that might be very difficult or very concern for her. It's not to downplay that in any way, but to also highlight that there are other cancer risks here that maybe the patient hasn't considered. And then this particular pedigree just talks about how just maybe the nuances of family history and how that can impact an assessment. So we're looking at this patient. She has colon cancer at 41. She meets criteria all by herself, even if we didn't have any family history. But I think it's important to highlight that her maternal aunt has had her uterus and her ovaries removed. That's what that abbreviation means, the TAH-BSO, that she has those organs removed at 40 for endometriosis. So she had them removed, she's having problems. That's not necessarily uncommon. But as I point out, it's hard to get cancer in an organ you no longer have. So because she doesn't have uterus and ovaries, we're not going to expect to see uterine or ovarian cancer in her. And maybe she wouldn't develop colon cancer, but she might have developed those cancers had she still had those organs present. And then the patient's uncle died at 19 in a car accident. He didn't have children before he passed. So we wouldn't expect to see him with Lynch syndrome related cancers at 19. So this family history doesn't necessarily seem like there's a lot going on, but we know that her grandmother has had endometrial cancer at 47. And maybe her mom is out of the picture. She's not close to her. She doesn't have a lot of info. So we can't say whether mom is affected or not. So this is one of those things where family dynamics and just random kind of nuanced things might make a family history look like there's not something going on, but there very well could be a mutation in this family. So there's some testing logistics, just in terms of what the test looks like, how's it done. You have sample types, you have blood or saliva. They're equally accurate, even though I feel like people don't believe me when I say that. But if there was a huge difference in accuracy, I really doubt the labs would offer them. I feel like that would just be more problems for the labs in the end. And then turnaround time, about 2 to 3 weeks to get your results. I'm going to touch on the panel options first. So you could do a focus panel, which is usually going to be like just a colon cancer panel, which is about 20 genes. The picture to the right is an example of those 20 genes that you might have tested. You can see APC there. You see some of the Lynch syndrome genes in that third row. All of these genes, any of these genes could explain a patient's, risk for colon cancer or family history for colon cancer or polyps. Or you can do a broad panel, which is about 80 plus genes. The bigger ones are 80 plus genes. And then if you choose to self-pay for this test, so not go through insurance, or if you get denied by insurance, it costs $250. So that's the self-pay price. It's come down a lot over the years, and by the way, the focus panel is $250. And the panel that's 80 plus genes is also 250. So it's all 250 in the end. Will my insurance cover this? I get asked a lot. It's hard to say 100% yes, 100% no. Sometimes I get surprised. Insurance companies kind of do their own thing a lot of times when it comes to genetics. So that's what makes it hard to determine. But do you meet criteria? If your insurance is likely to cover it, do you meet criteria to begin with? Which is why we start with family history. Have you met your deductible / max out of pocket for your insurance? If you have, then likely a lot of the services you might be getting past that point could be covered. Do you have a known pathogenic mutation in the family? If someone in your family is tested positive, please bring the report if available. That information is very important. It could influence how that provider, the genetic counselor, talks to you about your risks. You know, MLH1 guidelines versus PMS2 guidelines are different. Also, does your family actually have Lynch syndrome? I definitely talked with a patient where he thought his brother had Lynch syndrome, but the mutation was in CHEK2, which is not a Lynch syndrome gene. Luckily, I had the report before I spoke with him, so I was able to give him that information. But you definitely don't want to spend your 45-minute session or hour-long session, hour and a half long session talking about a hereditary cancer syndrome that's not even in your family because you didn't actually have the report and didn't really know what was going on. And then if you order a cancer-specific panel, your insurance might be more likely to cover it, especially if you meet criteria for that thing. And then it's not likely to cover if you don't meet criteria. And I feel like the insurance companies as of lately have cracked down on this a little bit. So if you do not meet criteria, it's not that you can't have testing, but I would say probably be prepared to pay $250 because it's likely going to go that way. And then if you haven't met your deductible or max out of pocket, if your insurance just doesn't cover genetic testing, then, they're not going to cover it. And then if you've had genetic testing in the past, I probably should have put an asterisk here. It can depend, but if you have like the same exact insurance and they paid for this panel 2 or 3 years ago and you try to do it again, they're probably just going to say no for that reason. And then on insurance discrimination, so people ask about this, they think about this, they're worried about this, and they ask me, there's a law called GINA, the Genetic Information Non-Discrimination Act, and it basically protects people from insurance discrimination. So it makes it illegal for your health insurance company to deny coverage because you have a pathogenic mutation or a family history of a pathogenic mutation, even if you yourself haven't done testing yet. So that's for like medical insurance. They can't see that you're positive and say, well, see you later, we're kicking you off the plan. They can't do that. Where it's limited is in things like disability and long-term care insurance and life insurance. With the life insurance, if you have a plan already, it's covered. But if you're trying to get a new one or make kind of changes, you may want to do that first, get that squared away, and then do the genetic testing later. So that's something to keep in mind. All right, so this is the contact info. This is the crew that we have here, myself and 4 other really great genetic counselors. I also give a shout out to our genetic counseling assistants, our medical assistant, and our schedulers as well. We all work as a team. We have a lot of patience and try to, get everyone seen, and wait times can be long, but we're, doing our best to provide, as quality care as we can for people. And if you want to call or email us, there's that contact info there. And then, just the student in me, always cite your resources anytime you give a presentation. But these are also resources that you can, access, the free websites that I just went on there, looking through the information. And they have like diagrams, and I think one of the sites even had a family letter template that you can just like fill in your name and send to your family that you've tested positive for Lynch syndrome. So I thought that was great. And then March is colorectal cancer month. I know it's not March, but in case you were curious, it is. And screening saves lives. So encourage your friends / family to get colon cancer screening. And note that I said screening, not necessarily testing, because the screening is what the testing is for. So if you know somebody, or even if it's you yourself, and they're thinking about it or they're on the fence about it, just try to encourage them. And there's different screening options. I know a lot of patients talk about Cologuard and things like that. So I know colonoscopies can be daunting, but if you ever happen to be having a casual conversation with a family or friend and they mention that they haven't done any colon cancer screening, then you may want to encourage them. And then, yeah, that's it. It's questions. I do have some extra time today, so if there are a lot of questions, we can definitely kind of hang around a little bit longer to answer those. But thank you guys for your time.
Thank you, Jazmine. That was an awesome presentation. You filled an entire hour, but that was so much information. I know it was a lot of talking for you, but I appreciate you doing that and covering everything, especially, breaking down those family history grails and, talking about insurance. That's something that's a lot of concern for people. And you mentioned at one point, if somebody wants to get testing because they have a family history and requesting those records, do you know specifically, and I'm sorry if you mentioned this, what they need to be requesting from their family member's physician in order to get an appointment with genetic counselor, or to, talk to their insurance about the requirements?
Yeah, so if you have a family member that's tested positive for Lynch syndrome, say it's a cousin, if you have genetic testing, that is like important information about you. It is something that you should have access to. I know here in our office, every patient gets a copy of their report either in the mail. We can also release it digitally. So your family member might just have their own copy, but if they don't, whatever doctor, genetic counselor, whoever ordered it for them, then they should have a copy of it and be able to pass it along. So that is important information. You should have it saved somewhere, but if not, your doctor might have it. And it can help with justifying to insurance that you meet criteria. I actually had this situation about a week or so ago as a patient. His mom had like colon cancer in her 70s, and there was nobody else in the family. So just that, like, he didn't meet criteria. Even his mom didn't meet criteria, and she actually did have cancer at some point. But the referral said that there might be Lynch syndrome in the family. And I told him, if you can get an actual report that your mom has Lynch syndrome, her age won't matter. She has Lynch syndrome. You have a 50% chance. That's it. Like, that's all of the proof that we need. So it can be helpful to have it.
Thank you. And if anybody else has any questions, feel free to enter them into the chat. Also, I'm just speaking directly about colorectal cancer. It seems like there's been an increase in young people being diagnosed with colorectal cancer. Are you seeing that with your counseling appointments, more young people and any causes associated? I mean, I know it was on a lot of people's mind last year with the diagnosis of Chadwick Boseman and his passing. Any comments on that?
Yeah, I think it can depend. Sometimes the patients we'll see for colon cancer, some of them could be in their 40s or like late 30s. I will say during like tumor boards, sometimes it can be like half and half. Like half of the patients are like all under the age of 45 or 40, and the other half are like, older people, 70s, 80s. So I feel like I've seen a lot of cases more recently since I've joined that one, of young people with colon cancer. And again, no family history. So they're 35, they wouldn't be doing colonoscopies anyway, which that's what kind of makes it a little scary, because how would they have, they wouldn't have had a reason to be doing that to begin with.
Yeah, and possibly changing the requirement or the recommendation for when somebody gets screened with all these new young people.
Yeah, they've moved it down from 50 to 45. I heard someone say realistically it probably should be 40, but it's more of a bandwidth issue. Like there's just not enough providers to offer screening for like everybody as they hit 40 for a colonoscopy. So that's also a challenge.
All right. I think there's just a lot of thank you comments in the chat. Well, thank you everyone for joining us, and I hope you have a wonderful rest of your day.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.